Welcome to Nyamira County. This vibrant county is home to lush landscapes and a warm community. However, amidst its beauty, Nyamira faces a persistent threat: malaria. A prevalence of malaria in this region has hindered progress and affected the well-being of its people, especially the most vulnerable. But in the face of this challenge, there is hope. The Catholic Medical Mission Board, or Cmmb, stands as a beacon of commitment to ending the menace of malaria in Nyamira County. Join us in putting a spotlight on what the journey has been.
Malaria remains one of the key public health concerns and one of the leading causes of death in this country and of course in this area. And this is especially for pregnant women and children under 5, which are really at higher risk of contracting malaria and of course probably being killed by malaria.
This area is swampy. Most of the times in the year, we have water logging all over. And as a result, we have the mosquitoes breeding in different sites, thus shooting up the cases of malaria.
Tuko mahali penye watu wanapiga matafari. Sasa sana yale mashimo yana hold maji. Yakisha hold maji, breeding inafanyika. Sasa na watu wetu huko ndio tunapata riziki ya kila siku. Sasa tunaenda. Wengine ama wazee wetu, vijana wetu, saa zingine inabidi walale pale. Wakishalala wanaumwa na umbu, wakirudi wanarudi na malaria.
When I came here back in 2021, I was shocked. The situation was really bad. The malaria cases around this area was that severe. In that you will find in a normal day the patients from the household, from the community, coming to seek the services were very many. A new clinician will be shocked in that how is the situation here.
We settled on these sites based on the high number of confirmed malaria cases. People were always sick. The community were always reporting cases around malaria within these communities that they're coming from. At some point, a child died, and at that point, we had to do something.
Kwa majina ni Esther Kerubo Ogongo, kazi wa Manga Sub-County. Kazi yangu ninafanya kazi ya CHV. CHV ni daktari ambaye anatoa huduma kijijini. Kabla wanakijiji waende kwa hospitali, wanaanzia kwangu kwanza. Cmmb tunakooperate na wao kuondoa malaria katika vijiji. Wametutrain mambo ya kupima malaria, jinsi ya kuona mgonjwa ama client, tunaita suspect.
The community case management of malaria, the approach is that the CHVs are supposed to visit all the households within their catchment within a quarter. But we were realizing that most of the time, this approach looked a lot more like a passive approach. So sometimes people get sick, they call on the CHV to come and look at them.
It was a big problem because it was all about walking from one home to another, giving the right health talks. On realizing the signs and symptoms, we could usually refer. But this referral could not bear us much fruits because when they come here, you will realize a very long chain that is now not making the work easier to the healthcare providers. And you find that this chain at times may not even be served all. Some will still go back home without being serviced.
So it got us to think on what other best way would there have been to be able to change the scenario that you're talking about? And that is how comes we came up with this PECADOM approach that was an active case detection approach where, unlike the cases when the CHVs were actually being called to go and visit the households, then the CHVs would ideally go to the households and make sure that they can visit them routinely so that it is a lot more active than it was passive. Within the approach, the community health promoters are supposed to visit their households that they man, what we are calling weekly sweeps.
We go house to house, we test any suspect who come with any sign that can be malaria, we must test. Because if we leave that person without testing, we might have a positive result that we have not tested. In case we test someone in a household and it turns positive, we also do contact testing, meaning if we get a positive case, we must test every person in that household, excluding a pregnant mother and any baby who is below 2 months, we don't test. But any other person, we test, so that in case there is a parasite in that household, at least we reduce tupate hiyo malaria mapema.
With this program in place, we have realized positive change because cases that have been realized in the community are dealt with there and then, not unless the complicated ones, like extreme malaria, maybe for children who are below 2 months. Those ones are referred to the facility for further investigation and management.
Hawa vile tuko wao ni jirani yetu. Ukisikia mbaya anakuja anakupima, anakupatia dawa. Si anaokoa badala ya uchape mguu na mguu hakuna. Na mguu ni chitiri. Utaona hii chitiri wapi? Sio ni ukufa tu.
So the project has done very well in the 6 months that it has actually been in existence. We have expanded the scope of coverage. We are getting a couple of people tested. Through the project, the CHVs are a lot more motivated. Testing is going on. And in terms of the continuity of the same, at least for the 6 months that the project has been there, there has been continuity of the service in terms of case management in the community.
The numbers we used to be seeing without this project, they used to be high. But currently, the higher part of it is being seen at the community. So it is a success. And every person in every household is now being reached. Because you can realize there are some patients who cannot afford to come to the facility, maybe due to finances and other issues. But now, because they are being seen, our community promoters do visit every household. Now they are easily accessed and they are given the service.
Kitambo tulikuwa tunapanda shilingi 100 na 100 kurudi. Sasa ingekuwa sio hawa wanatusaidia, ningeuza nini niende hospitali, si ningekufia kwa nyumba.
But I think the one last thing that I want to talk about is the issue of action. One of the things that we've done is that based on community dialogues that we are having with households, because it's one thing to come and test people when they are suspected to have malaria, but it's another thing to talk to them on how they can be able to prevent malaria. So we are having dialogues with these communities and talking to them about how can they be able to get themselves safe from malaria. For the 6 months we've done this, we've had about 12 of such dialogues in the areas that we're talking about. And after that, we have seen the communities come out to do certain actions towards clearing their environments, making sure that they can be able, basically issues around vector control and making sure that their environments are safe and not really depend on the CHVs to come and talk to them.
The coming in of this project is eminent to us as a community, is a privilege to us as a community, and we would like that the project continues.
The support we have seen has really impacted on us, and the community have been sensitized on the issues with malaria. We can say the project has a bit of work need to be done, at least to realize where we wish to be.
One of the biggest gaps that has existed in this program is the fact that we have focused a lot more, the project has focused a lot more on testing our people once they have already probably gotten malaria. But it is important for us, all of us as stakeholders in this program, to be able to still understand the vector dynamics in the areas that we work in. Because in doing so, we will be able to better structure our interventions to not only respond to people when they already have malaria, but we will be working with the communities to be able to prevent themselves from getting infected with malaria in the first place. The malaria patterns that we are seeing in these areas that we are working in is slightly different from what we are seeing in other areas. So it is important to be able to use this information so that we can structure our project better, to make it a lot more responsive and make it a lot more impactful.
Our prayer is we continue with the services. We keep on supporting these community health promoters so that they continue offering the service to the community.
As Cmmb, we expect the county government to be able to step up and really sustain this noble approach that we've had in terms of ensuring commodity availability for the CHVs to do their job and making sure that the CHVs, in terms of stipending them, to be able to make sure that that can be able to continue and make sure that they are motivated to provide the services to the community. It is important to us that the community can be able to receive these services when they need them, if they need them, if at all we are to account for the healthy and well-being of the communities.
Madao mimi nasema, madao nayo waongezee, madao inawaishianga, wagonjwa wingi, waongezee madao.
Moving forward, we could like the county and the Cmmb to at least look at least something that can help this area because we have a lot of brick makings, we have a lot of swampy areas during the rainy seasons, at least to improve, even to bring the spraying in and different forms of at least reducing this malaria.